something funny about me. So in junior high, I was the victim of being a paperboy, and that did not earn me enough money to do anything, so I had to find alternative means of raising money. And I actually took a dare to dress up in women's clothing for a day, which included a dress, high heels, and nylon stockings. I made $85, and it just so happened it was during Gay Rights Week, which I did not know. And I was the victim of lots of jokes for the rest of my education in my hometown. But anyway, that's stupid. I did it and I made money.
That was in Canada, right?
That was in Canada.
You don't get thrown out of school.
You do not get thrown out of school. In fact, to be honest, and I have to disclaim this, 40 of that $85 came from my teachers. So, anyway. No, so I like kids a lot. I've toyed with doing a pediatric fellowship, but my wife has put the stop to that just for time purposes. But I really do love them. I've got lots of them. And something that I just have always enjoyed is, I love working with the kids and the parents, but we don't see enough of the tricky stuff to really feel super comfortable with it. So I wanted to present a few cases. It started out with a goal of 10, it became 5 for time reasons. But what we're going to do is go through these topic by topic. I'm going to leave you with an initial slide with pictures or a description. And what I want you to do is just to kind of in your mind associate what you see with a certain disease process. And then we'll just talk about why and how we should kind of have that trigger in our head, what to look for. And you know, retrospectively, I looked at these and I thought, well, geez, I'm just, you know, what this really is an aggregate of signs and symptoms. It's taking a good history or it's doing a good physical. It's just something that pops out when you take the time to do it. And so, but anyway, hopefully it'll be helpful in some way. Okay. All right. What's the disease in kids that comes to your mind when you see this? What'd you say?
Intussusception.
Intussusception, okay. Coming from the Latin words inside and to receive. It's the most common cause of obstruction in children that are under 2 years old. We see it mostly in the 5 to 12-month-old, and it's about a 1 in 2,000. All of these diseases today somehow are more common in males than females, so you know, we just kind of got the short end of the straw there. But interestingly, siblings of patients with intussusception have a 15 times higher chance of getting it themselves. And why that is, they don't know, because there's no genetic links that they've found. And all of the etiologies that they've proposed are really infectious or other kind of acquired things. And if untreated, obviously the mortality is high. Talk about the lead point and the telescoping. The lead point is kind of this point in the bowel where when you have a peristaltic contraction, it stops it and causes the peristalsis to engulf the other piece of the bowel. So it's very common to have something like this 1 to 2 weeks after a viral illness because of Peyer's patches, the lymphatic tissue of the bowel. Lymphoma, HSP, which is Henoch-Scheinlein, something like that, purpura vasculitis, Meckel's, celiac, cystic fibrosis, and surgical scars. The location of these is most commonly ileocolic, but it's important to know that it can occur anywhere. And part of that is that the traditional way to diagnose this was with what test? Anybody know? So barium enema, air enema to reduce it. And if it's in an ileal location, you're not going to find that with your typical barium enema. So you need to look for it in other ways. So it can occur anywhere, but most commonly, yeah, not so much. Right here at your ileocolic junction. Here's the telescoping physiologically what would happen with the one segment going inside the other segment, like that. That leads to edema, which is a venous obstruction, and then you get ischemic valve. So the most common signs of this, and we'll see when we go through a couple of studies where they looked at ultrasound in diagnosing this, is that the child will have this intermittent colicky abdominal pain. It'll come on for 15 to 30 minutes, then it'll go off for 15 to 30 minutes. Kind of come and go, where the child looks very well, but then they look really, really irritable. They'll have emesis, and then they'll have some bloody stools. And emesis can be bilious because it's an obstruction. You see all three of them in less than 25%, and 2/3 at 75%. You might see the child drawing their legs up to the stomach, but it's also important to know that kind of the zebra presentation of an intussusception is the child that is just lethargic and does not appear well, and maybe a floppy baby. Physical exam, the classic finding is what they call Dance's sign, which is the mass in the right upper quadrant and then an absence of any fullness at all, and kind of a void in the right lower quadrant, and that's just because of the as the terminal ileum telescopes inside the colon, you get this kind of movement of where the bowel is, and you get that lack of anything in the right lower quadrant, but it's rare to find that. So imaging, plain films, you should see an obstruction. Ultrasound came into popularity in the 80s, and barium enema was the gold standard before that. This is what you might see on a plain film. Classic obstructive pattern, lots of air in the small bowel, and air fluid levels. So first used reliably in the early 80s, around 84, had been used from into the 70s though. A study out of the Netherlands between 80 and 89, they took 163 kids. They suspected the diagnosis after a physical exam and a plain film showed obstructive pattern. They went to ultrasound to confirm it. 33 children, ultrasound did not show intussusception. Of the other 130 children, intussusception was diagnosed in 128 of them. In the 2 children who it was noted subsequently, they did not find an ultrasound there. So pretty good sensitivity, great specificity. 65 patients suspected of having intussusception. 23 on ultrasound. They were all confirmed by barium enema. No false negatives. There were 3 false positives. But the question was, and they didn't comment on this at the time, this was done in the early 90s, but one of the methods for reducing these intussusceptions now, which is coming into investigation, is ultrasound reduction of the intussusception. And so I guess I would throw out there, were these 3 false positives possibly reduced during the ultrasound at some point? And thus were not found on follow-up. Again, good sensitivities and specificities. Here's what you might see. It's a target sign type lesion, which is essentially bowel inside a bowel. You can imagine cutting the telescope in half and looking at it down that segment. That's what it would look like. Treatment of choice is the air enema, but the contraindications to that include perf and peritonitis. So a child that you think has an acute abdomen, you would just send them right to surgery. Here's what the barium enema might look like. You can see that there's an abrupt stop to this contrast. Somewhere over here, it looks to be about the ileocolon junction. And here you can see there would be a void in the right lower quadrant. And you might find this mass in the right upper quadrant, and that would be consistent with what was Dance's sign. These are just some notes on how they do the barium enema. I guess they hang the bag of barium about 3 feet above the table, let it go in. Then they've got this rule of 3s. You got 3 attempts, 3 minutes, and 3-foot barium column above the table. But the big part of this, and why we have a hard time having these children here, is that if it fails, if the enema fails, you need to have surgical backup. And we don't always have that here. And here's why. So 2 studies we're going to talk about for this. One was at Indiana, one was at India. And 244 children over 15 years at a tertiary care center. Interesting that their symptoms complex. 81% vomited, 61% had the bloody stools, and 60% had the abdominal pain. We find that pretty reproducible over these studies. 190 patients had the attempted reduction with 46%